Hi, everyone. Welcome back to the Breast Cancer Podcast. Hello, I'm your host, Dr. Deepa Halaharvi, a fellowship trained breast surgeon, and also happen to be a breast cancer survivor, thriver, and a warrior, living my best life. As you know, breast cancer affects millions worldwide, touching lives in a profound ways. Whether you're someone facing a diagnosis or a supporter seeking information or just eager to learn more, this podcast aims to be a beacon of understanding, hope, and empowerment. I'm here to talk about all things breast cancer, from surgery to survivorship, as well as high risk for breast cancer to metastatic breast cancer. My goal is to provide you with reliable information, share inspiring narratives, and foster a supportive community. I know firsthand the challenges breast cancer diagnosis brings. Throughout this podcast, I will give you strategies to handle difficulties that arise from cancer diagnosis. We'll have insightful conversations with medical experts, researchers, survivors, caregivers, and advocates. I will tackle topics that impact our lives as cancer survivors. My goal is to educate you and empower you to live your best life. I definitely have. Well, let's get started. Hi, everyone. Welcome back to the Breast Cancer Podcast. Today, I have the famous Dr. Syed Mohsin. He's a breast pathologist here in Columbus, Ohio. And I have to say, he is extremely respected, very well known pathologist, very much published. And he also happens to be one of my mentors in my fellowship, and he continues to mentor me in different areas of my life. And I just feel like it's such a privilege and an honor to have Dr. Syed Mohsin here with me. And oftentimes, patients will open their my chart and will see their pathology report and they're panicking and they go to Google and start Googling things, which is what I usually say. Dr. Google did not go to medical school, so don't do that. So today I have the expert and he's here to answer any of your questions and which I have written them down here. And then when you open your pathology report, hopefully this will give you a little bit more insight to understand the basic terminology and your pathology report. So welcome, Dr. Syed Mohsin. It's such an honor to have you here today.
Good morning, Deepa. I'm very excited having the opportunity today. We certainly talk about friends, family, and other folks who have questions, and they know that I'm a pathologist and kind of get to know what I do in their care of breast diseases, breast cancer, and related health issues. And so I had that opportunity, and I've been thinking about finding a forum to connect with all of you. So I'm very grateful that Deepa started this series. And I know it's been fantastic. I've been listening to them myself and hoping that we continue that series that's beneficial to all of you. So
yes,
thank you very much.
Thank you. And again, it's such an honor to have you here. I respect you so much. And a little story on Dr. Mohsin. I was diagnosed with breast cancer and I got the results on a Friday. Dr. Mohsin just came back from Pakistan, I believe on Saturday. He went to pathology lab and he did the hormone receptors. And I don't know if you remember, it was about almost 10 years ago now. Next year is just crazy, right?
It's amazing how time flies.
Yeah.
And nothing better to just see you like, I don't want to say it hasn't happened, but it feels like it.
Yeah.
You're like totally like always known Deepa for so many years, and she has been like this for several years. So that's, to me, is the great success story that we like to share, obviously, so with everyone.
Thank you so much. So, Dr. Mohsin, I'm going to get into it today. And, I say pathologists are unsung heroes. They're doing so much work in the background. And every treatment decision that we make is based on pathology. And so I call Dr. Mohsin the pathologist, the doctor's doctor. We are waiting for him to tell us what to do, for us surgeons and medical oncologists and radiation oncologists to take the next step. So I'm going to actually ask Dr. Mohsin, what is a pathologist? Who is a pathologist?
So I'm glad. I think it's a great question, really, really basic item. A lot of medical terms have Latin background. So pathology or the pathologist is the person who practices pathology is two words. Pathos means disease and logy means study. So these are physicians and doctors trained to study disease patterns. And in the context of today's talk, what we do as pathologists is if patient has a lump or a abnormal mammogram ultrasound and the tissue, a piece of that abnormal tissue is removed, the pathologist will actually examine it. If it is big, we look at how it appears, but really under the microscope to look at very, very deep characteristics. And we put it together in the pathology report for some very, very useful information that Deepa just talked about that really helps making a treatment plan for each patient. So that's what pathologists do on a day-to-day basis in this team of physicians that are going to be with you, whether it's a surgeons or oncology,
Yeah.
a genetic counselor. So, there's a host of us in the healthcare or part of your team taking care of you.
Yeah. And we are very blessed where we work. We have fellowship trained breast pathologists. And I think that's actually really important. And you are part of our multidisciplinary conference where there is surgeons, radiologists, radiation oncologists, pathologists, and medical oncologists. And it's really important, whatever institution you're at, to seek out that institution with a multidisciplinary conference because it takes an entire team to put together your treatment plan. And so, anytime, a patient has a biopsy, whether it's a needle biopsy or surgical excision, it takes a couple of days to get the results back, right?
Correct. So, so a little getting into how do we get to the
Yeah.
place where we can generate a report.
Yeah.
So when we remove, and we'll talk about what is tissue and so on a little bit later. So we receive the stuff that is removed, as Deepa mentioned. It can be a small sample we call needle biopsy, or a better term is minimally invasive biopsies, often used
Yeah.
if you hear that term. And or sometime, of course, the big surgery when we're really removing a big piece of tissue. It requires a lot of preparation to get the tissue to a place where it can be examined under the microscope. So that is at least a 24-hour process or overnight process. And ultimately what happens, we put the tissue in a paraffin wax, so it's really preserved for a very, very long time. And from where that we basically slice it really, really thin, put it on a piece of glass called glass slide, and we put some colors on it called stains. And that makes the tissue visible under the microscope. And then we kind of examine it, look at a lot of its characteristics, and we put it together in a nice, concise, the one we call the pathology report for you. So that part alone will take about 1 or 2 working days to get to that spot. And of course, we're going to talk about if we do end up diagnosing breast cancer, we have to do some additional testing or ancillary testing. Sometimes we use the word breast predictive factors because they help us determine how that cancer is going to behave, number one, but more importantly, what treatments will be most effective.
Yeah.
So we talked about these receptors, right? The hormone receptors, and another one called HER2. I will come back and talk. So that requires another sometimes 1 day or 2 day, depending on how extensive that. So you're looking at easily 2 to 3 days minimum to get the whole.
Yeah, and you'll understand a little bit later as to why that's important for us to formulate a plan for your treatment. So we'll get right into it. And so I usually tell my patients when I'm describing breast, I usually say breast is like it has lobules and ducts. And I usually say it's like grapes and ducts. And this is a lobule where it makes the milk, and there's a duct. Milk goes through the ducts to the nipple. And so I just was talking to Dr. Mohsin prior to this podcast, and he has a really interesting way to explain breast anatomy and also what is cancer.
So 2 big questions. So let's start with anatomy means, how a part of the organ or body is organized. And so, as it's a great example to actually show you the tree. So there are 2 kinds of trees if you think about it. Classic one has a big trunk, and then the branches come out at the end. You have leaves, but the most important part is that flower and seed at the end, right? So breast is like if you're familiar with what's called a maple tree or Japanese maple, it doesn't have a big trunk like that. It starts like that and immediately goes into the branches, just the way she showed you. And then basically it ends up this grape-like structure or lobules. So this structure, which is called the ducts and lobules, are called the breast glandular tissue. And glandular tissue has to be supported by additional tissue. And so A way to explain it, imagine a wall in a room. Of course, in the US, we use wood and
Mm.
stuff like that. But most places, when you talk about a wall, it is made of bricks. So you notice that bricks have a very, very fixed shape, and they're all very similar looking. And so glandular tissue is like the brick of the wall. We often call them the cells, individual unit. And then to keep the bricks together, you have what we call either grout or cement or something that's called connective tissue. So in breast, the epithelium or glandular tissue is arranged just like Deepa showed you with this grape-like structure. And in between, we have the supporting stroma or tissue, which is made of mostly fat. It has collagen, which gives it the strength and the shape to maintain it. And within them, of course, every piece of the body requires oxygen and nutrients. So they come in blood vessels. We have arteries, veins, and very, very important structure called lymphatics. And
Yeah.
we're going to come back to it because it's very important as well.
Yeah, that's really great explanation.
So your second part of your question
Yeah.
is, what is cancer?
Yeah.
So our body has organs and tissues. They have very, very specific functions. So we talked about breast. Breast is primarily, its function is that when women becomes a mother, it's gonna produce the milk. And for that reason, it is going to grow and during the pregnancy and typically under hormones and other body structures and proteins. So what cancer is that when the normal cells are always dividing to keep up because every cell has a defined age. So when they go away, they have to be replaced. So it's a normal function of every tissue that some cells are always dividing to replace. When the cell division happens, although there are a lot of mechanisms to make sure it is very orderly, but sometimes for factors sometimes known and sometimes unknown. You talked about predisposition. Have you heard the genetics of the breast? Um, the normal cell transforms, and some of the things that happen is that it loses its growth control. It doesn't have the parameters, the orderly growth. And when it does not, it will become a cancer cell. And there's a lot of details to it, a lot of factors that go in. But one of the key part of cancer is that it does not have the organized growth. It grows at the expense of others, and so on and so forth. And that may help you when women have breast cancer or any other cancer. One of the things is they lose weight because the cancer cell basically suck up a lot of nutrients for their own growth. So these are some of the characteristics of cancer cells, and we'll again look at it as we go into pathology report, how that it appears under the microscope, how it is, and I think imaging is a different modality. You can see that by mammogram and ultrasound as well.
Wow, that's a really good explanation, and that's exactly what I tell patients: is cancer is this division of uncontrolled division of cells, abnormal cells, damage. It happens as a result of a damage to the DNA, and so when I see patients and I'm explaining to them cancer, and usually the pathology report will say invasive cancer or in situ cancer. What is the difference between that, Dr. Mohsin?
So in situ, again, coming from Latin, something that is still in its original place where it should be. So what does that mean in breast? So we just talked to you what the normal breast looks like. So we have ducts and lobules. So remember I talked about individual unit of the glandular tissue in breast is called a cell. And cell, I gave you an example like a brick in a wall, very, very similar looking, a very fixed shape. So an in situ cancer is that when cell has transformed, have become a cancer cell, and I'll give you a little bit more example of that. But as long as it is still in the milk ducts or within the lobules, although it will distort it, but you can still see it. You know what I mean? So then we call it is in situ. It still is in the original place. And on the other hand, invasive cancer is the one that has left the milk ducts, and now the first thing it gets into, we talked about this supporting tissue called stroma, right? The fat and the collagen and all that. So it's gonna get into that and start what's called invading there. Like, so what the word cancer really means in Latin is really for crab, something that has these tentacles, right?
Wow,
It goes out. So that's why the word cancer is used. So coming back to analogy of normal being the brick, imagine that one brick starts to go bad, it starts swelling up, and now it's no longer rectangle. It may become round or irregular. And if you see it, you can spot it, right? This brick
Yeah.
is bad. So as long as the brick has all this shape and all this gonna press on the next one, if it doesn't cause the wall to fall off or anything or it creates hole, that will be in situ because that cancer cell is still in the wall. But it becomes so bad that wall starts falling off, the plaster falling off
Yeah.
into the room. That will be a first part of invading, right?
Invasive.
Because
Yeah.
wall is supposed to be in the wall and not in the floor or ceiling.
Right.
So that's how the invasive cancer happens. So it starts to spread outside the milk ducts and
Yeah.
lobules.
Wow. That's a really great explanation. That's something that I haven't heard before. So thank you for explaining that. The one often confusion people have is grade and stage. And when they look at their pathology on my chart, they see grade, they automatically assume it's the stage.
Yeah.
How would you explain the difference?
So the great thing. So let's look at what Deepa just talked about is the information you see in your pathology report. Most of the reports have multiple sections in it. First of all, we get a history of what's going on with the patient. If Deepa or a radiologist has taken a tissue, they tell us where they took it. Is it right or left breast? And also, sometimes it's more specific what part of that breast it is. Is in the outer side, the lower
Yeah.
side, and things like that. And then the pathologist has the two very important components, what's called gross description. So they tell us how much tissue they received, what it looks like. But what we're talking about, the crux that Deepa is focusing on and all our care team
Yeah.
is the final diagnosis section.
Yeah.
And it will tell us, first it will confirm that I'm examining the right breast tissue that was removed by a biopsy or excision. But then I give you two or three very, very important pieces of information. One is called histologic type, and second one is called histologic grade. So let's focus on your question,
Yeah.
grade. So grade is it's a great history. Basically, in 1928 or so, one of the great surgeons, Dr. Greenough, he used to examine tissue under the microscope from the patients he has removed. He started looking at under the microscope and he said, listen, I can actually look at the cancer cells and look at 7 or 8 characteristics of them and figure out whether this patient has an indolent cancer or aggressive cancer.
Oh, wow.
So he put all these two together into 3 grades, 1, 2, and 3. It was just an arbitrary. So what does it mean? He said the 1 is the one in which, okay, they're cancer cells, I can tell, but they still kind of a little bit look like normal. They still maybe more square, and they're not so big, maybe 2 or 3 times larger than normal.
Yeah.
He looked at the shape of the cells. Is it round? Is it polygonal? Is it square? All that stuff. And the third thing he looked at is the cell dividing? Because normal cells in breast epithelium, 1 in 2 or 300 cell, I may see as a dividing cell.
Yeah.
But here he's seeing almost 5 or 10 or something like that. So this is called mitotic figure, mitotic or dividing cell. So he put all these together in 3 grades and looked at what happened to these patients and noticed that if the cells are very big and irregular, they have a lot of dividing cells and they are like large, like 5, 6, or 7 times the normal. That's a grade 3 tumor. And grade 1 will be opposite of that, and grade 2 will be in the middle.
Yeah.
So grade really tells us in summary, by looking at these microscopic characters, is that how aggressive tumor may be growing. And it translates into the clinical behavior as well. So that is grade.
Yeah.
Stage is coming back to our analogy, when cells cause so much distortion in the wall and they start going out of their confines. So now it is invading breast tissue. It may invade the lymph nodes in the armpit on the same side. We talked about lymphatics, that's how they get there. Or unfortunately, if it spreads elsewhere, right?
Outside your breath.
Outside the body. So stage is different. Stage is that when we diagnose a patient,
Yeah.
how far tumor has already spread.
Yeah.
As we talked about, it can be in situ in the milk ducts only.
Yeah.
It can be in the breast. We will call it early breast cancer.
Yeah.
And so on. So I'll elaborate a little bit on stage.
Yes, please do.
So we use the system called AJCC's, American Joint Cancer Committees.
Yes.
We are at the 8th edition of that. It uses a very classic system in all cancers. Breast is no different. We look at three characteristics. One is called T stage or tumor stage. It's about the size of the tumor.
Yeah.
And we use both the imaging studies, ultrasound mammogram, some are MRI,
Yeah.
but primarily, and also clinical exam.
Right.
If your surgeon can feel it, he or she will measure it, and that is called the clinical stage or T stage. But when pathologists measure it in the microscope or by looking at tissues, called the pathologic T stage. So we have four of them. T1, T is actually, I'll call it five.
Yeah.
They have a T0 when it's still in situ in the dots, and the T1 is any tumor between 1 million, from 0 to 2 centimeters. And then between 2.1 and 5 is T2, and anything above 5 centimeters is T3. And then we have a T4 when tumor is very aggressive. It starts to either invade the skin, causing ulceration, or the chest wall behind the breast. So that's T4. So we take that part of the staging as T stage, and then the lymph nodes in the armpit on that side. So if you have no lymph node, it's called N0 for node 0. And then we have up to 1 to 3 nodes will be N1, 4 to 9 is N2, and then 10 and more at N3. So, and the last one is M disease. So that is only to either tumor has not spread outside this area or it has. So we put them together into 4 stages. And so we have a combination of T stage, N stage. M automatically makes it stage 4.
Right.
But the combination of T and N will make it stage 1, 2, and 3.
Yeah.
So,
And then that's a great explanation. And then there is what's called hormone receptors.
yes.
And how does that play a role? And what is hormone receptors? And how does that play a role in staging?
So male, female bodies are different, and one of the key compounds that drive some of our characteristics and function are called hormone receptors. So, and they are produced by the reproductive organs of that. So in women, it's going to be ovaries. The two very, very important hormones are called estrogen and progesterone. So these are produced by the ovaries, and they several parts of the body, particularly female-specific organs, breast, endometrium, ovary, they have what is called a receptor. So what is a receptor? So imagine an analogy of a lock. So lock itself, where the keyhole is, that's the receptor, and the key is the compound. So estrogen will be the key, and you remember only one key will fit to unlock
To a
the door,
lock, right? It's
right?
very specific key to a lock.
Exactly.
Yeah.
So estrogen will only attach to its own receptor called estrogen receptor.
Okay.
So what's in the context in breast cancer? So the breast cancer, because they're arising from breast epithelium always have estrogen receptor because that's normally how it grows. So in cancers, we know approximately 75 to 80%, I'd say about 80% of breast cancer still retain estrogen receptor, and they're dependent on their growth. Although it is a cancerous way of depending on it, but it is still. So if there is a circulating estrogen, it's going to attach, it's going to cause the growth of cancer cells. So it is very, very important for us to see whether the cancer still have estrogen receptor and how much.
Yeah.
Because we will have treatment to block the estrogen binding to those cancer cells, so that receptor is nullified and does not cause what we call extra effects. So that is estrogen receptor. And progesterone receptor is very much related to it. The primary one that we really need to know is estrogen receptor. But when both receptors are positive, we have learned that all the treatment we use called anti-estrogen treatment modalities are most effective in breast cancers that show both estrogen and progesterone receptor.
Right. And do men have these estrogen progesterone receptors?
Great question. You're saying, oh, well, as men, they don't have ovaries, right?
And that's the question I get asked for male breast cancer.
So we'll get a little deeper in it. So in the big family of estrogen and progesterone, there are other organ systems in the body that are common to both men and women that produce it. So adrenal glands and actually body fat cells have ability to create low level of estrogen. And you guess what? You all have it.
Yeah.
Men. So coming back to men just a little bit, because they don't have to, the pregnancy and lactation is not thing men, but they still have this ductal structure. You showed very rudimentary, but it's still there in the same area. So as you talked, you had a
Yeah.
great series of male breast
Yes.
cancer, and
Yeah.
so men can develop breast cancer. So yes, they also develop breast cancer, which will be similar, which will in terms of estrogen and progesterone receptor, they have it,
Yeah.
and they depend on a very low level of estrogen, maybe produced by adrenal glands and fat
Yeah.
in the body for their growth as well.
Yeah. Yeah. And I know you touched a little bit on pregnancy. And in pregnancy, we tend to see more triple negative breast cancers. Do you agree with that?
Yeah,
Yeah.
exactly. You know, at the age of pregnancy is going to be, you know, you're talking about 20s and
Yes.
30s.
Yeah.
And traditionally, you know, most breast cancers, we start thinking about it after 50,
Yeah.
unless there's a high risk or family history. So, yeah, so these are younger women. There's a lot of reasons, some we understand and some we don't understand, is that during pregnancy, you know, every woman who has gone through, no hormones are going all
Yeah.
over the place. They're very high
Yeah.
because that's how the body is prepared. So yeah, we do see a lot of women don't, the cancer that arise during pregnancy do not show expression of
Yeah.
estrogen receptor on
That's
it.
interesting to me. I
Exactly.
find that interesting. So, Dr. Mohsin, so we'll again circle back to the staging question. And you did a great job. And you mentioned AJCC 8th edition. Prior to the 8th edition, we were not including the grade and the hormone receptors into staging. And now, 8th edition, we do include grade and hormone receptors.
Yeah, it's a great question. And, you know, this is fascinating because
Yeah.
when I started working in this field a year ago, we were probably at 5th or 6th edition. And this TNNM, the tumor size, the node and M methodology is still there. But we are so grateful that we have learned so much
Yeah.
about in breast cancer
Yeah.
that now we call in the 8th edition, besides TNM staging, we also call this called prognostic groups.
Yeah.
And what it is, it still includes the TNNMs part of it, but now we have reliable information that grade into 1, 2, and 3, estrogen and progesterone receptor status, the other molecule we haven't talked about, HER2, and sometimes proliferation. Besides, I mentioned in grade, we do talk about the dividing cells, so it is part of the grading as well. But there are even other ways that you can measure proliferation. So we have so much reliable data that we can actually refine the group of women who have breast cancer into more smaller subsets that are more unique and really tailor their treatment plan because we have this information. So I think it's a great advance, and I think, as you know, we also are incorporating some molecular data into it.
Right.
As I think we will touch upon it a little bit later.
Yeah. No, that's great. So you touched on two things that I want to clarify for our listeners. One is you talked about a proliferative factor, and that's oftentimes is referred to as Ki-67, correct? And how do you describe that?
So Ki-67 is a very specific test. It is measured pretty much like we measure estrogen and progesterone receptor. But we are looking at a specific proteins in the tissue, and it's a special technique called immunohistochemistry. Ki-67 is just the name of that test. What it does is that it looks at any cell in the body, whether it's normal or it's cancer, which is in the act of division itself. And there's a term for it called mitosis.
Yeah.
If you see that, that's what it really means. So Ki-67 test is one of the tests that can actually mark the cell that is dividing. And the way we report it is a percentage.
Yeah.
So we will say a Ki-67 index is 15%. So anything below 20% in general, so there's different studies showing whether you want to use a 10% cutoff, 14 or 20, but I'll generalize it. Anything less than 20% is a slow growing potential or less proliferative. Over that, it becomes more.
Yeah.
After 20%, I don't think it tremendously adds any other subset. So that's pretty much what it goes to. Yeah.
And then we'll talk a little bit about HER2/neu.
Yeah.
What is that?
So I mentioned the acronym HER2. So H stands for human, E for protein called epidermal growth factor, and R obviously for receptor, and then the number 2. So what does that mean? There are others? Yes.
Yeah.
So there is an HER1, it's also called EGFR1, and there is a HER2, as you mentioned, HER3 and 4.
Yeah.
What we found in breast cancer specifically is that this family of proteins called HER proteins, the HER2, the second one, is the most important. And it was described in 1987, and I have the privilege of being trained by those great scientists who actually described it. And the great story really in treatment is that in 87 description, within a few years, a very, very specific antibody was developed to actually block this protein. And so just to general, if you want to touch upon later, is HER2 is approximately 15 to 17% of breast cancers have what we call overexpression of this protein. When it is overexpressed, then we can target it for treatment.
Right. So what you're saying is even for those patients who are HER2 negative, still have some HER2, but they're not overexpressed. Is that correct?
That is correct. So so a lot of tissues have HER2. It's a very, very important receptor. It has some growth factors and maintenance functions. But in breast, without getting into scientific, yes, normal breast epithelium has something, but it has to be substantially higher than we call, that's the word we use, overexpression for it.
Yeah, that's right. And again, going back to the staging, AJCC 8th edition incorporates what Dr. Mohsin talked about, the tumor size, the lymph nodal status. M stands for metastasis meaning cancer outside the breast, also the grade and the hormone receptors. And so hopefully that makes sense to you as when you're looking at your report, and hopefully that also it will make more sense in a little bit when we talk about hormone receptors and how its implications in treatment of breast cancer. Before we go into that, you mentioned one thing, Dr. Mohsin, is genomic assay that's also incorporated into staging.
Right.
Which particular genomic assay would that be?
So we started looking at, as I mentioned, these hormone receptors. This data goes back to 1970s when we start measuring estrogen and progesterone receptor. As I mentioned, HER2 came around in 87, more in the research arena until the medication was developed and tested in 90s. So we had to develop a test. Again, it was ideally it was similar to estrogen and progesterone receptor. And as we were studying what other molecules are related to estrogen, progesterone receptor, or HER2, we identified several other ones. So the question was, will they help us narrow down? It is good to put these patients with breast cancer in specific characteristic groups. But if we can personalize their medicine, that would require a little bit more refinement. So that's why we looked at it. And one of the tests that came out and is available is called Oncotype DX. And these were the folks who did a lot of basic science on this molecule, HER2, but they also developed this test. So it is a 21 gene panel. And when you say gene versus receptor, just to make sure, when we talk about gene, we're talking about DNA or nucleic acid of that particular molecule. And when we talk about that molecule, when it makes the molecule, it becomes a protein. So the difference is that these molecular tests are typically not looking at protein. When I say I'm measuring estrogen and progesterone receptor or HER2, I'm measuring the protein part of it in the tissue. But we can also measure their DNA part of it or RNA part of it. So these tests like Oncotype is based on RNA test, and it looks at some estrogen-related proteins. It looks about 4 or 5 of HER2 related protein, and it also has some Ki67 or proliferation related protein. There are about, I think, if I can remember correctly, about 16 of them are related to that. And the 5 are what we call them in our own term housekeeping. We have to make sure that the quality of assay is as good or perfect before we report on it. So it's a great thing that the company has done to have a very, very reliable assay. So this is one of them that is very, very commonly incorporated
in the staging. I mean, these are all very important things for our listeners to understand. Is when you're looking at your pathology report, you're looking at what type of cancer, and then you're looking to see your grade and hormone receptors. And this is important because Dr. Mohsin and his colleagues help us surgeons, the medical oncologists and radiation oncologists, how to tailor the treatment. And it's really important because the Oncotype DX tells people whether they need chemotherapy or not. But there's a subset of hormone receptors. So it's those patients who are hormone receptor positive and HER2 receptor negative. If your tumor is greater than 5 millimeters, you are a candidate for Oncotype DX. And there's several other assays that people use across the country and across the world. There is what's called Mammatome, there's PAM50, there's Blueprint, there's a number of different ones out there. Typically at our institution, we do use the Oncotype DX, which is part of the NCCN guidelines, the National Cancer Comprehensive Network guidelines. And this is also fascinating, Dr. Mohsin. We touched on the Oncotype DX for those patients who are hormone receptor positive, HER2 receptor negative. And that's why it's important to know that prior to having a discussion with you about your treatment plan. And there are those patients considered triple negative.
Yeah.
And who are they? And what makes them triple negative?
So triple negative means 3 negative tests. So estrogen receptor negative, progesterone receptor negative, HER2 negative. And so somewhere around 5 to 10% patients in that neighborhood, at least in the population we see, are going to have all of those 3 tests negative. And so a little bit more information. What does that really mean in terms of how that patient is going to behave, how that tumor is going to be? Triple negative typically means an aggressive tumor. Why is that? Because estrogen and progesterone receptor being present on breast cancer cells not only tell us that the anti-hormonal treatment is going to work, it also tells us one more thing. Overall, in the big picture of all different kind of breast cancers, these are still a little bit more indolent breast cancers. Again, I don't want indolent doesn't mean it's anything benign or not life-threatening, but they will have less chances of spread out, recurrence, and so on and so forth. HER2 is a different molecule. It's a part of what we consider an oncogene, and these are tumor provoking kind of gene. So these receptors, what is the characteristic of HER2? Has the ability to make the cells very mobile.
Yeah.
Which means that they have easy way of spreading.
Mm.
So besides the ability that if the breast cancer is HER2 or HER2 positive, they can be treated, which is a great thing. But when this treatment was not around, that was a bad news for patients.
Yeah.
So now you put that combination, that lack of estrogen and progesterone receptor makes that tumor aggressive because no longer have it. Plus HER2 is there, that's bad thing, but we have learned that these are probably the most aggressive kind of breast cancers that we see. So yeah, it gives us a pause when we see all triple negative. Oh, how are we going to manage this patient?
Right. So there's implications for the treatment if you're triple negative. And we are doing a great job, as we have been doing a good job in HER2 positive space with the targeted anti-new therapies. But we're also doing a good job in the triple negative space where there is immunotherapy like Keytruda, and we're seeing good pathologic response, which translates to good overall survival. So those are all really good. And this is again goes back to telling us why cancer is not one size fits all. And this is where Dr. Mohsin comes into play. He tells us how to treat you. And so one person may need chemotherapy, the other person may not need chemotherapy. And so you cannot compare your pathology report with somebody else's pathology report, even though it may look superficially similar. Every cancer patient is different, and we tailor your treatment according to your pathology and the biology. And biology is a big thing these days, right?
Right.
Yeah. And you mentioned Oncotype, which is based on the biology, and there's other assays we discussed earlier. And we're learning more and more about the biology. So it's not so much as a surgeon, me taking out the cancer, I can do that, but it really depends on the biology of the cancer. And we'll go into a different topic slightly, which is also relates to pathology, is the lymph nodes.
Sure.
So, for invasive cancer, now we didn't talk about ductal cancer versus lobular cancer. Let's actually go back to that before going to lymph nodes.
So remember we talked about the pathology report. Actually, in pathologists, we have our own set ways of reporting everything. So first thing you're gonna, as Deepa mentioned earlier, is gonna tell us the type of cancer, because the in situ carcinoma. And we never just report inside. There'll be a word before that, ductal or lobular. And so what does that ductal mean? So there's something called histologic type. Typically is reported for us. We will call invasive ductal carcinoma, invasive lobular carcinoma, something like that. So the most common histologic. So what is histologic type? Same idea. When we looked at the tissue under microscope, they have certain growth patterns. And, just look at different trees. They have all different, you can tell it's a tree, but every tree has its own characteristic. The leaves are different. The branching pattern is different. The shape of the leaves are different, so on. So same thing happens with breast cancer. It grows, it has many patterns. So one of the most common kind of breast cancer, I'll say roughly about 80% or so, are called invasive ductal carcinoma. And sometimes it's called invasive ductal carcinoma, not otherwise specified. Or sometimes you will see the word no special type. So what do you mean by special versus non-special? So we looked at certain characteristics. We identified some smaller numbers. So these are going to be within 5 and 10% of breast cancers. They have a very, very typical appearance under their microscope. So one of them is called tubular carcinoma. It is a very, very grade 1 invasive cancer. It always make what we call tiny little glands, which are angulated. When you look at it, you can exactly tell it is. And it is a very, very good kind of cancer. So it's always estrogen progesterone receptor positive. It hardly metastasizes to a lymph node. So it's a good one. So we call it a special type, tubular carcinoma. There is another one called mucinous carcinoma.
Yeah.
It makes a very clear gel-like material, and that's called mucin. Again, maybe 1 or 2% of all breast cancers fall. Again, this tends to be grade 1 or grade 2, tends not to metastasize much, maybe less than 10% to lymph nodes. So it has a good. So that's a special type. And the another one is called the lobular, which is the second most common. I'll say maybe 12 to 13% of breast cancers fall on that. It's very unique. There's nothing like it. And because it don't form gland-like structure, it doesn't try to resemble anything normal. And it has a tendency to have a single cell growth pattern. I give an example. When you look at it, it looks like it's like a rain drizzle coming down through it. And like a ductal cancer is like, a storm comes through and just, even from like 50, 100 feet, you can tell, oh my God, this tree's branches are all off. You can tell. Lobular cancer is like, it's just raining.
Yeah.
So nothing happens to the tree, it's just wet. It goes right through the normal. It doesn't cause any reaction. So it makes it harder for us to feel it.
Yeah.
It's harder to see it on mammogram
Yeah.
and ultrasound.
Right.
So that's a specific type. So these are called histologic types. Before we learn more about grade, before we learn more about the hormone receptors and molecular assay, histologic type was useful in putting these patients into at least 2 or 3 groups.
Yeah.
But then if these are not the special types, the tubular, the mucinous, and there are also smaller types, less than 1%, you will see there are 18 or 19 of them. We report them out. But now we have learned that the other molecular factors, the receptors, are more useful information in treatment. But it still has a place and a tradition, so we report them out because there is some differences in metastatic patterns and so on and so forth. So if you cannot put them in a special type, we just call them invasive ductal carcinoma, and then grade is very, very useful there.
Yeah. That's a really good way of explaining the lobular and ductal.
Yeah.
And I call it lobular a sneaky cancer.
It is.
It's really difficult sometimes to find it on a mammogram. So sometimes you have to get an MRI. And it's also difficult to treat sometimes. They are not, they usually typically do not require chemotherapy. But, again, every cancer is unique and we tailor the treatment to that person. So lobular cancers can sometimes be tricky cancers. So I'm really glad that you explained that. And now going back to the lymph nodes, so anytime there's invasive cancer, the recommendations are do a sentinel lymph node biopsy if they don't already have a positive lymph node. Even when you have a positive lymph node, sometimes we still do a sentinel lymph node biopsy. And we can go into that at probably a different podcast because that involves a lot of nuances in different studies as to why we do that. But a sentinel lymph node essentially is the way that I describe it, Dr. Mohsin, I don't know how you would describe it, is the first draining lymph node. It's the sentinel, is the first draining. So it's the gatekeeper underneath the armpit. And if all the fluid and everything that drains from the breast, it typically goes through the axillary lymph nodes or the lymph nodes underneath the armpit. How would you describe a sentinel lymph
No,
node?
it's a great, and remember when we were giving analogy of
Yeah.
the wall and break.
Yeah.
So stromal tissue, I talked about three kind of blood vessels. So arteries bring the oxygenated blood, veins take it
Yeah.
out. I talked about another kind called lymphatics, and a lot of women will experience or know the during menstrual cycles, some women, particularly right before their period, feel the heaviness in their breast.
Yes.
It's a part of a premenstrual syndrome or something. Is because the later half of pregnancy, of the menstrual cycle, has a lot of progesterone in the body, and it causes some water retention. And breast is no stranger to that. So once that happens, that fluid has to go away. That's where these lymphatic spaces normally do.
Yeah.
So, and one of the good part or can be bad part about lymphatic channels is that they take away bigger molecules away or proteins. So their walls are a little bit more loose and open. Unfortunately, cancer cells are smart and they use that mechanism to escape from breast tissue into these lymphatics.
Yeah.
And what these lymphatic channels do from breast is that they're going to converge onto a kind of a reporting place in the lymph node in the axilla. So sentinel lymph node is the first one.
Yeah.
So what do you mean by first one? If I put a little dye in the
Yeah.
breast around it and give it a mesmer, that was one of the techniques we used, right? And you follow that dye, you're going to see that it goes through, the lymphatics become blue, and then you find it, right?
Yeah,
Deepa?
correct.
So that's one of the methods. And of course, you use another method in combination to host. So the idea was that if the cancer is going to try to escape, if we can find the first node, the sentinel, we have the highest chance of knowing that the cancer has already gotten into the lymph node. So that's, exactly. So the first node, or sometimes you have more than one or two nodes, they call sentinel nodes. You can number them, or there's some other terms used. Exactly.
Yeah. So sometimes on the pathology report, it's reported as isolated tumor cell or micrometastasis or What does that mean?
So remember, we talked about in TNM staging, the big picture is that how many nodes are involved.
Correct. Yeah.
And then we learned, okay, we are good at these numbers, 1 to 3 nodes, 4 to 9 and more than 10 and more. Then we start learning more, and it says how much cancer cells are present in the node, the quantity is also important for us. And so it becomes very important when we calling about N1 stage, 1 or 2 nodes. I really wanted to know, because we don't want to overtreat patients also, right? So, so there are 3 terms we use. If the tumor in the lymph node measures 2 millimeter or larger, then we call it a macromet, which is like a big size met. And it can be anything greater than that. Then micromet is, now we're really talking about small stuff, 0.2 millimeter up to 2 millimeter. So it only can be seen under the microscope, and it is, you have to be basically able to measure. And the last term you use, it gets even smaller, isolated tumor cells. So how did we even find it, right? It was a curiosity. So what happens when we start doing, instead of removing all the nodes, X-ray dissection, we start doing this mapping called sentinel lymph nodes. So we only have 1 or 2 nodes submitted to pathology. And we said, we really need to look closely at it. So we start looking at making multiple slices of it, doing extra stains called keratin stain and so on. And all of a sudden we start finding cells, 2 cells, 3 cells, 10 cells. So isolated tumor cells is less than 200 cells approximately involving. And I said, what does that mean? Is that the same as micrometastasis or macrometastasis? We found out that if we have to use special techniques to find these 1 to 200 cells only, that is not going to threaten that patient's life. So what we do is that you're going to see in your pathology report, we'll still call this N0. But then we're going to put in parentheses, by the way, I used, I think usually called I, which is we use immunohistochemical stain to find those cells. We'll say I plus to it. And if we did the stain, because if we don't see anything under the regular slides, we still do the immunostain called cytokeratin or keratin. And if you still don't find it, we will still say, I examine the sentinel node. I also use this special, highly sensitive technique. And then I still did not find it. So I will put in parentheses SN, which is sentinel node, parentheses with I negative sign, which simply saying that I did try And I used that technique and I still didn't find, which is very reassuring at that time. Yeah.
So, Dr. Mohsin, that's a really good explanation on the lymph nodes, on what it means to have isolated tumor cells, micrometastasis or macrometastasis. Obviously, again, there's implications for treatment based on that. So, whenever the pathology report comes out, patients ask, what does it mean, margins?
Yeah. So a lot of stuff we talked about is what we call initial diagnostic biopsy. We're putting histologic type, grade, estrogen, progesterone receptor, and HER2. Now the next part that pathologists examine is the specimen from the surgery itself. It can be a lumpectomy, it can be partial mastectomy or total mastectomy. So question is, what does margin mean? So really what Deepa as a surgeon's goal is that she wants to remove all of the cancerous tissue. And what she tries to do is that she wants to at least have a rim of normal tissue around it. So margin is the distance of where cancer stops and where Deepa has removed the lump or the tissue that she has removed. And we use different techniques. What we do is when we get this specimen, when we start looking at the microscope, because it goes through so much processing, I cannot really tell where the original surface was where Deepa cut it. So we typically use what they call margin inks, and it helps us keep the orientation. Because God forbid, there's a small chance that we cannot feel or see little tentacle of the tumor, right?
Yeah.
You thought you got very well around it under the microscope, but it's still kind of trickling around.
Yeah.
So it is important for Deepa to know if a cancer cell is touching where she cut it, what is that margin looks like? Is it up, below, side, or front or back? So we use 6 different kind of inks to mark it. So when we look at the microscope, we can exactly measure. It can be a fraction of a millimeter sometimes.
Yeah.
It's very accurate. So margin is to tell us, reassure us that we have totally gone around the cancer.
Yeah. And that's important. It decreases the chance of cancer coming back in the future if you get negative margins. And it depends on if it's invasive cancer versus in situ cancer. And studies have shown if it's invasive cancer, you want no cancer on the ink. What that basically means is what it says is no cancer on the ink.
Right.
If it is in situ cancer, and they usually recommend about a 2 millimeter margin. And why is that, Dr. Mohsin?
So as we mentioned, the in situ carcinoma is still growing inside that breast duct.
Right.
And imagine if you have a big tree, there's so many tiny branches. So the cancer cell somehow not has the ability to invade, but it can still spread in the tiniest ducts. So, and those are almost, you cannot see them, right? And maybe when you talk about the abnormalities in mammogram, one of the things is calcifications. And in situ, or ductal carcinoma in situ, one of the markers is calcium in it, but it's not at every place, not every tiny duct has calcium in it. So there is no way for us as a surgeon or a radiologist to know where it stopped. So we have found that sometimes if it looks like that carcinoma in situ stop, there's a 1 millimeter margin between the ink. Maybe there is a brag that I'm not seeing. The reason is that breast tissue is a 3-dimensional structure, right? And we are only looking at 2 dimensions for everything. So there's a chance there. And we have learned over the years that if you start to be less than a 0.5 millimeter, 1/4 millimeter, it's okay for invasive cancer. In the ductal carcinoma in situ, we have seen some of those patients had tumor has regrown.
Yes. Oh, yes. Yes.
So that's why we have become a little bit careful that ideally, if you can get 2 millimeter margin, then we know that it is very reassuring.
Yeah. And I will say, as a surgeon, the 2 cancers I dislike operating on is ductal carcinoma in situ for the same reason, because it's really hard to predict the margins just looking at the imaging, because imaging is our best guess. Mammograms, MRIs is our best guess. The final thing that determines your treatment is pathology. And that's why we call Dr. Mohsin doctor's doctor, because he tells us whether we got all the cancer or the margin's okay, and that then patients can go on to radiation or other treatments. So pathology is the final say in getting a treatment plan together and also figuring out if the patient needs additional surgery. I know you mentioned calcifications, and I want to switch gears a little bit just towards benign breast disease. This is the area where I see a lot of patients who come in with abnormal mammogram. They come in most of the time with calcifications. And patients often ask me, what are the calcifications?
So there are calcium deposits. So hope you can go on Google if maybe you had an opportunity to look at a mammogram. It's an X-ray. A lot of stuff is dark, but calcium reflects the X-rays and it shows as white spots. And so the radiologists have learned over the years that when the calcium deposits show up in breast, there are certain patterns, and they classify them on using a classification system. Certain patterns, particularly if they call it pleomorphic, when these calcium deposits vary in size.
Correct.
If they start to line up like they're lining up the ducts, it's very concerning.
Yeah.
And that's a very, very typical feature of ductal carcinoma
Yeah.
in situ.
Correct.
So that's what the calcium is, and that triggers a lot of biopsies. Certainly, if there is a new deposit,
Yeah.
unless it's absolutely benign appearing, which is very large, rounded configuration that can be washed, maybe. But typically, you have to sample them to
Yeah.
just to ensure that it is benign versus is associated with something more.
Yeah.
Yeah.
Why do the calcium deposits develop in the breast?
So we have limited understanding of why it develops, but at least in ductal carcinoma in situ, we see them both in what we call, by the way, in ductal carcinoma in situ, we also provide a grade. It's called
Correct.
nuclear grade
Yeah.
1, 2, and 3. The ones which are higher grade, they grow so rapidly
Yeah.
that they start running out of their blood supply. Um, and they expand the duct. Imagine from half a millimeter duct, it becomes almost 2 or 3 millimeter, which is enormous on microscopic level. So when they go, they undergo what is called the cells that are farther away from capillaries and blood vessels, they die. And when they die, we call it necrosis or chondronecrosis.
Yeah.
That's where there are certain proteins involved in
Okay.
creating calcium
I got you.
deposit. It's
Okay.
kind of like tombstone in a cemetery, kind of
Yeah.
just telling there was something
Yeah.
there,
Yeah.
but this is all gone, and we
Yeah.
want to leave a mark there. So
Yeah.
that's what calcium
I
is,
see.
at least in that
Yeah,
context.
that's a very common question I have because we say, and Dr. Mohsin did a really great job explaining what a DCIS or ductal carcinoma in situ looks under a mammogram. Typically, it's a pleomorphic, meaning irregular shape and size. It could follow a duct. But majority of the time that I see these patients have benign pathology. They come in, we usually say 80% of the time your biopsies are going to be benign depending on how it looks on a mammogram. And so, what is then the pathology process for those benign patients? Why do they develop the calcium deposits?
Uh, Most of that has not been either investigated
Okay.
or studied. There are certain proteins that exist and just the development of lesions that have been associated with probably cause the calcium.
Yeah.
But honestly speaking, we really don't fully understand why calcium develops.
Yeah.
Some benign nodules, something
Yeah.
called fibroadenoma,
Correct.
a
Yeah.
very, very common benign lump,
Yeah.
often develop calcification, but it's typically what we call both larger rounded configuration. There are other benign lesions called columnar cell lesions or sclerosing adenosis. They have fine calcification they develop. Again, we don't understand
We don't
why,
understand. Yeah.
but all we know is that when we see them in that configuration in mammogram,
Yeah.
and radiologist puts them into low risk
Correct.
category,
Yeah.
BIRAT 3 or something like that.
Yeah.
Pathologist is already mentally prepared that
Yeah.
you're gonna find something benign there.
Yeah. Yeah. No, that's great. I think we have so much literature in cancer. We have guidelines, and there's all these different organizations telling us how to treat cancer. Oftentimes, as a surgeon, it is tough sometimes to treat benign breast disease because we really don't have as much research and as much data. And one of them being like radial scar.
Yeah.
What is radial scar?
So, as you mentioned, scar, radial means something that's kind of like a burst kind of thing, right? And radial is also kind of redundant in that. So it is a lesion that is very, very important and causes confusion because one of the characteristic feature of breast cancer, invasive breast cancer, is a distortion. What do you mean distortion? It makes something abnormal.
Yeah.
And in mammogram is going to be something more gray and white area, which has very irregular borders. I mentioned cancer means crab, it has tentacle.
Yeah.
So radial scar is a lesion, which is by itself is a benign lesion.
Right.
But it has two important parts. It resembles on mammogram like a cancer because it has this irregular borders and edges. But other thing is very, very important. When these radial scars develop, it is a very long process.
Yeah.
And it has both, which we talked about, stroma supporting tissue, but it also have the glandular tissue. And the glandular tissue can undergo changes. And the reason we often end up having, even radial scar being benign, surgically removed, is that it can harbor some precancerous changes.
Yeah.
And the last important aspect of radial scar is that the central part of the scar under the microscope really looks like invasive cancer. It looks like a special type of cancer I mentioned called tubular carcinoma. It has this small angulated gland. So that's what I wanted to emphasize, that when we talk about benign and precancerous lesions in breast, there are a lot of them. They have a lot of overlapping histologic features. Some of them can mimic invasive cancer or in situ carcinoma. That's where a experienced and ideally a fellowship trained breast pathologist is very, very important. And I like to emphasize to our listeners here is that if you're diagnosed something with a precancerous and you talk to your surgeon and physician, we say, listen, this is something puts you at increased risk. We need to watch you. We need to manage that risk. I think it's not a bad idea that getting a second opinion because it can change how your surveillance plan is going to be, right? So I think that's important. So radial scar has a history that it has been overcaught as cancer and the patient had a big surgery and only to find out it was ultimately benign, and so on and so forth. So so it is a lesion that mimics.
And you make a great point on why going to an institution where there's a fellowship trained breast pathologist is important. And if you ever have questions, I think it's always okay to get a second opinion from another pathologist. We sometimes have our two pathologists read pathology, right? Even in our own institution.
Yeah, remember we going back to our approach and approach at all good centers, academic, whether in the US and other places, is multidisciplinary. And one of the key feature of that is that we have at least some sort of treatment planning or treatment review. Everybody sits together. We read everything, right? The history, the imaging, the pathology, what treatment we're going to offer. And so part of that is so that forum of multidisciplinary automatically ensures that it has been reviewed. Pathology has been seen by another person. But also, as Deepa mentioned, sometimes there are certain unique cases, as I mentioned, the precancerous lesions, that really should be looked at. So in our institution, unless it's an absolutely straightforward breast cancer, invasive ductal grade 2, there's no question in imaging, no question in anything. That's perfectly fine. A report is issued by one pathologist, but it gets reviewed within a week by another person when we discuss it together. But in all other cases, I'll say almost 100% time, majority of premalignant lesions that we diagnose, already 2 or 3 people have seen it. I just want to make sure, because it has such a huge implication.
Absolutely. And I think what I appreciate about Dr. Mohsin, as you all can see how brilliant he is, and I absolutely adore him, but he is very conscientious. His colleagues are very conscientious. Every microscope, they're reading, they know that there's a patient behind it. They look into the history, they call the surgeons, and that's something I want to say to you. Like, I'm so grateful. You are a doctor's doctor, but also you are such a patient advocate. And I think that's really important to have that. We've done a great job in covering cancers. We've done a great job in covering some of the benigns. I just want to talk a little bit about the atypical cells. We did talk about ductal carcinoma in situ, which is non-invasive cancer, but there is another entity called the atypia, whether it's in the ducts or in the lobules. And is it the similar pathology in terms of the atypia?
Yeah, so we now, for the last couple of questions, talking about precancerous changes. So we learned a lot in the US particularly. So I go back to 3 larger institutions here. One is called National Database out of Tennessee. Huge studies were done. What they did was, this is talking about patients in 70s and 80s, and they said, well, certain of the patients had either a lump or something like that was removed, and it has some we call proliferative breast disease or benign proliferative disease. They followed these patients for essentially for 10, 15, 20 years and looked at it that So some of them developed breast cancers and some did not. So so they had this epidemiological approach to call risk assessment. So are these histologic changes in breast epithelium predict that some of these patients are at higher risk? So that's why we defined the pre-cancer or pre-malignant. So one of them are the atypical hyperplasias. So um, so atypical hyperplasias in general will increase the risk of the breast cancer, whatever the baseline that may be, with or without family history. It adds another 4 to 5 times increased risk for the rest of her life from the diagnosis. So there are two types, atypical ductal hyperplasia and atypical lobular. We'll focus today on atypical ductal hyperplasia. The way it was defined was first defined by the group in Nashville, and they were looking at something that was a ductal carcinoma in situ, low grade or grade 1, but was very tiny. Do we really want to label this patient having a cancer? The word carcinoma. If I call some a woman ductal carcinoma, she is labeled now as a breast cancer patient.
Right.
And they looked at it and they figured out if this lesion is less than 2 millimeter, then the risk was not like ductal carcinoma in situ. What does that mean? Back in 70s, 80s, if a woman had a low-grade ductal carcinoma in situ, and they don't get the full treatment, so they just had a small biopsy, we diagnosed it, right? And we leave that patients for some reason cannot get surgery. We looked at it. She has 10 to 12 times increased risk for the rest of her life to develop breast cancer, and actually, given enough time, 5 or 10 years, she definitely will have it. But with this atypical ductal hyperplasia, the risk was only 4 to 5 times. So there's a lot of time left before this thing will progress. So what if I just remove this? We know she has tendency, but we have really minimized the risk or eliminated the risk. So atypical hyperplasia is one of the more advanced precancerous lesion, which has almost all the characteristics of low-grade ductal carcinoma in situ, except it's tiny. It's less than 2 millimeter. So we label that, and you're probably gonna cover that in another podcast, how those lesions have to be managed and how they increase the risk.
Correct. And also talking about, Dr. Mohsin mentioned how you manage them. It keeps changing on how we manage these lesions. Back in the day when I was in training, we excised almost all the atypical ductal and lobular hyperplasia. These days there is a strict guidelines. If there's a lot of atypical ductal hyperplasia, there's good recommendations to remove it. And there's some other things that patients have to do, such as talking about taking chemoprophylaxis, which is like tamoxifen or aromatase inhibitors. They also need to be monitored regularly, not just with a mammogram, with an MRI. Depends on their family history. This is where your breast cancer risk assessment is important, where they take your numbers and plug it into these computerized models. It gives you the risk of what is the lifetime risk of developing breast cancer. If your lifetime risk of developing breast cancer is more than 20%, you're considered high risk for breast cancer. So we definitely will. We have covered it in other podcasts. I will continue to cover it. Breast pathology is not simple. It's pretty complicated. And again, it's not one size fits all. Pathologists who are working tirelessly behind the scenes are truly the unsung heroes. We covered a lot of information in this podcast. We talked about benign lesions. We talked about atypical lesions. There's one other thing I want to cover before we finish is fibroadenomas. My young patients typically get diagnosed with, come in with a mass on the breast, and they're usually, anxious, as there's so much exposure to breast cancer, so they worry about it being a cancer. So typically, they get a biopsy, and the results come back as fibroepithelial lesion. We don't know if it's a fibroadenoma or a phyllodes tumor. And why is that? Why is that difficult to diagnose in pathology?
So these are rounded lumps that arise, and they have the word fibroepithelial, 2 words here. Fibromen has a lot of this stromal tissue or collagen, and epithelium is the glandular tissue. So these are called lesion which has both components in them. So there are 2 related lesions. Overwhelming majority, I know, say probably 90% plus of these are totally benign ones called fibroadenoma. And they have certain different patterns that pathologists like to talk about, but at the end, they're just benign fibroadenoma. These are really for us to recognize that it's benign. But it has a counterpart to it called phyllodes tumor, Phyllodes. It had an old name called cystosarcoma
Yeah.
phalloides. And the reason was that before we had good breast screening and imaging and mammogram and ultrasounds, I'm talking about 70s and 80s, they were diagnosed when they have become cancerous.
Oh, wow.
So now we have changed that term and we call it phalloides tumor. They look very much like fibroadenoma, but the the stromal part, the fibro part, transforms into a neoplastic process. And now we divide them into three types. There's a benign phalloides tumor, borderline malignant, and malignant. Malignant are extremely rare.
Yeah.
And they tend to be larger. I would say more than 2 or 3 centimeters. So if somebody's talking about less than 3 centimeter,
Yeah.
it's not going to be malignant ultimately when it's removed. But the issue is that the fibroadenoma and benign phalloides tumor tend to look very similar. There are few characteristics very, very important. Um, the fibroadenoma has a totally rounded edges. So once we remove it, it's not going to come back. The benign phalloides tumor has a little bit of tentacles in surrounding tissue, but it is not uncommon. I always talk to people. Say, "Deepa, it just came out. It just popped out when I was in there, just like a fibroadenoma does." But under the microscope, we said, "Sorry, your margin is polycystic, and that's the unpleasant part of it." She has to go back. So when that little part is not completely removed, it has chances of coming back. It will come back still with the same benign phalloides tumor. Very rarely it will transform. We believe that the malignant one, by the time you diagnose, is already kind of malignant. So that's the difficulty. So on a small needle biopsy, we cannot assess its complete edges. That's where it goes into the surrounding tissue. So we end up saying, listen, I'm not sure. And because the stroma kind of looks funny to me, like a phalloides tumor. So we use a generic term called fibroepithelial lesion that includes both fibroadenoma and phalloides tumor. If it is a malignant one, I can diagnose in a biopsy and you exactly know.
Oh, okay. That's
because it has the malignant characteristic features in it. But it's the benign one, we are not sure. So it's called as fibroepithelial lesion. And we wait for an excision to make sure what type it is.
Wow, Dr. Mohsin, thank you so much. This is all such wonderful information. And I hope the listeners appreciate the pathology and what goes into it. And I cannot do my job without Dr. Mohsin and his colleagues and all the work they do behind the scenes. And I hope you get to appreciate how much goes into our treatment management and our plan. And we really like our physical exam, imaging, like mammograms, MRIs, are our best guess. But really, what really is important before we can formulate a plan for you is the pathology information. And they are doing work behind the scenes. Every patient, every image that they're looking at a microscope is a patient, and they're very conscientious about it. And they ask a lot of good questions. And I hope you appreciate why you want to go to a center where there's multidisciplinary conference, where the whole team comes together to formulate this plan for you. And again, don't compare your journey to somebody else's journey, because your cancer or benign disease is unique to your case. And it's not one size fits all. And we take pride in saying that we provide personalized care for you. And Dr. Mohsin, I cannot thank you enough. And this is a lot of great information. You would have helped millions and millions of people. This podcast is in over 127 countries. And I hope it increases, because this is just a valuable information. And what's my goal of this podcast is to empower you so you can advocate for yourself. Knowledge is power, and I hope we empowered you today. And now you can see why I admire Dr. Mohsin. He's full of such great wealth of information, and he broke it down into such understandable analogies. And I appreciate you. Thank you so much for taking the time to be here today. And if you liked this podcast, please share it with others and give it a good 5-star rating for us. And this just will help us promote this podcast to to other people. So thank you so much for taking the time and joining us today, and have a wonderful day. Bye-bye.
Thank you, Deepa. It was my pleasure. And anything we can do, as you mentioned, the goal is to empower you. But as you mentioned, Dr. Google is good enough for certain things, but it is your local care team.
Correct.
People who know you best, your circumstances. They're going to be the best group of healthcare providers, whether it's physician and other team members, to give you what you really deserve. Breast cancer is your breast cancer is your breast cancer.
Yeah.
And we want to do the best that we can from information we gain from it and help you. Thank you. My pleasure.
Thank you so much. I appreciate it. Thank you, everyone, for tuning into the Breast Cancer Podcast. Remember, you're not alone in this fight. I encourage you to be an active part of this podcast. Please share your stories, questions, and suggestions for future topics at my website called drdeepahalaharvi.com. And please share this podcast with others, especially if you found it useful. And please also give it a 5-star rating, if you will. Stay connected as we navigate the complexities of breast cancer. Until next time, take care and keep shining brightly. Disclaimer: this podcast is not intended for complete medical advice.